that can diagnose the luteal phase defect. Now, etiological factor beyond progesterone may be pinopore's development, insulin-like growth factor binding protein, integrins, cytokines, etc. The tests to detect these abnormalities are experimental and they are not used in clinical practice. So, all this research which is going on integrins and cytokines, this is not useful for the diagnosis of the luteal phase defect. There is some controversy in the diagnosis that LPD can occur with the normal progesterone level. I told you that when it is not appreciated at the endometrial level, that in spite of normal progesterone, you can have a luteal phase defect. There is no correlation of endometrial histology with the serum progesterone level, and at present, no test can stamp the diagnosis. That is why always the treatment has become difficult, and that's why you have to anticipate that which are the cases in which the luteal phase defect can occur, and in these cases, even on an empirical basis, you can start the luteal phase support. Many studies suggest that not the estrogen nor the progesterone, but the estrogen-progesterone ratio is much more important rather than the progesterone level. Serum progesterone and estradiol benzoate are not related tests. Duration of exposure is more important than the blood level for timing of an embryo transfer. Suppose for an embryo transfer, either on day 3 you require 3 days of progesterone, or for day 5 you require 5 days of progesterone. So it is not the level that is important, it is the duration that is very important for the embryo transfer. Now, in a luteal phase defect, what you can give to the patient? One, you can induce the ovulation. Second, you can give HCG to this patient. And third is the progesterone supplementation can be given to the patient. Now, for ovulation induction, you have clomiphene citrate and its adjuvants, you have letrozole, you have gonadotropin, or you can do ovarian drilling for ovulation induction. And here, when you induce the ovulation, the quality of the follicle will be very good. And when the quality is very good, estrogen level is normal. When estrogen is normal, the positive feedback mechanism, the LH surge will be normal. When LH surge will be sufficient, corpus luteum will be normal. And when the corpus luteum is normal, progesterone level will be normal. And when the progesterone level is normal, that will not be luteal phase defect. Insufficient luteal function is a consequence of an inadequate follicular activity, and ovulation induction causes better cohort of the granulosa cells. High E2 level because of the good follicle gives the high progesterone, and so the pregnancy rates are very high. Clomiphene citrate. Clomiphene causes the high LH in the luteal phase and abolishes the need for the luteal phase support. That's why majority of the clomiphene cycle, they do not require the luteal phase support. CC occupies the estrogen receptors and may cause an LPD. This is one of the reasons that has been put forward for the luteal support, but majority agree that the luteal support is not required for the clomiphene cycles. Reduction in progesterone receptors are not seen even if they occupy the estrogen receptors. There are sufficient progesterone receptors, and that is why luteal phase defect does not occur with the clomiphene cycle. Circulating estrogen is enough for upregulating an LH and progesterone receptors. Only 50% can have LPD with clomiphene citrate, but majority of the papers say that it does not cause a luteal phase defect. Abnormal folliculogenesis because of the increased LH may be the cause. We discussed also that whenever you give clomiphene citrate, the LH level is high. That is an advantage that the luteal phase defect does not occur. But when there is a high LH, it deteriorates the quality of an ova, and that is why the corpus luteum which is formed may be the defective afterwards, and that can cause a luteal phase defect. CC plus estrogen is not beneficial in majority of cases. Second is an HCG supplementation. It stimulates the theca lutein to produce more progesterone and other steroids that are required for maintenance of pregnancy. It is administered every third or the fourth day. It increases the placental protein 14 and relaxin that helps for the implantation. So, HCG stimulates the corpus luteum to secrete the progesterone and other hormones which are required for maintenance of the corpus luteum, as well as it helps to secrete the substances which are required for the implantation. The disadvantage of HCG supplementation is that it increases the incidence of ovarian hyperstimulation syndrome, and that is why it has gone absolutely out from the IVF patients people never give the luteal support with HCG. It should not be used when the E2 is more than 2500, 1600 units international unit in an intrauterine insemination, and 4000 international unit in the in vitro fertilization are responsible for giving you OHSS. It may increase E2 and may alter the E2 progesterone ratio, which is detrimental for implantation. And that is why the HCG, because of the OHSS, because of increase in E2, which changes the ratio, that is not indicated as far as the luteal support is concerned. HCG can be given on day 3, 7 and 10 post-ovulatory 2000 units, or day 5 and 9 post-ovulatory you can give as the 5000 units. This we will be discussing that when we give GnRH agonist as a trigger, it causes a luteal phase defect, and Professor Umedian has said that 1500 units at the time of an IUI, if you give HCG, it rescues the corpus luteum and the luteal phase defect does not occur. Progesterone has a very important role in inducing, facilitating an LH surge, and it is also required for the full responsiveness of the pituitary to gonadotropin releasing hormone. So, progesterone is slightly increased just before an ovulation, and it has a very important role in facilitating the LH surge. For ovulation, that is why rise of progesterone is always necessary. Secretory endometrial transformation and receptivity depends solely on the duration of exposure to adequate progesterone concentrations, provided that sufficient estrogen priming has already occurred during the follicular phase. So there should be sufficient priming with the help of an estrogen, and then only the progesterone level can be normal. And second, for luteal phase support, exposure to adequate progesterone for a good number of days. So the duration is very important so that it does not cause a luteal phase defect. Role of progesterone: it causes vasodilatation and squashes of uterine muscle by inducing the nitrous oxide synthesis in decidua. Uterine relaxing property of the progesterone prevents the expulsion of the embryo during and after the transfer. And that's why uterine contractions are common in the beginning, but once you give the progesterone, that is in a blastocyst transfer, when you give it for 4 days, and the 5th day when you transfer, the chances of uterine contractions are quite less, expulsion is less, and the pregnancy rates are very high. HC injection for ovulation trigger supports the luteal phase for 5 days. And that is why you may not require the progesterone as a luteal support up to 5 days when HCG trigger has been given. But afterwards, because HCG is an exogenous LH, it decreases an endogenous LH, and that causes a luteal phase defect because the endogenous LH is decreased, and that's why the progesterone secretion is less from the corpus luteum. So the growing embryo will start secreting HCG from day 8. So this is between day 5 to day 8, there is a progesterone deficiency, luteal phase defect is present, and that's why abortion rates are high if the progesterone is not supplied, or the chemical pregnancy is very common. Older patients and endometriosis require the longer exposure to progesterone because of the progesterone resistance. All superovulated cycles require a luteal support. In all superovulated cycles, the estrogen levels are high, and this high level of estrogen will decrease the FSH and LH in the follicular phase, and this decrease in LH will cause the luteal phase defect, and that is why all superovulated cycle in an IUI or in an IVF. So here in IUI, we require always a progesterone support in all superovulated cycles. Now the type of progesterone, we have got synthetic progesterone and vaginal micronized progesterone. In synthetic progesterone, we have medroxyprogesterone acetate and dihydrogesterone. Vaginal micronized progesterone was significantly more effective than the oral dihydrogesterone in creating an in-phase secretory endometrium. That's why vaginal progesterone is considered as better than any other progesterone. Natural progesterone, you have the different routes, that is intranasal, sublingual, rectal, oral, vaginal, and intramuscular. Now out of these 3, that is intranasal, sublingual, and the rectal routes are not used, and what we use now is oral, vaginal, and the intramuscular progesterones are used. Oral progesterone is ineffective in inducing an in-phase endometrium. It causes drowsiness, flushing, and nausea. Sedative or hypnotic effect is found with the oral progesterone. Oral progesterone and dihydrogesterone fail to foster the pre-decidual transformation.